ones that give me the hardest time. So I am here to talk to you today about obesity and obesity management in general. I'm not here really to focus on one drug overall, but just more the fact of like, how do you think about obesity and what can you do? Whether you are in the hospital sending these patients home, whether it is a patient who is being admitted for surgery and that patient gets the bad news that they're too heavy right now to be considered for surgery, or what would be the next steps in your care plan for a patient when you get to see them on the outpatient side. What is our first intervention? So let's say you have a patient who has high blood pressure. What is the first thing you would do for that patient when you decide on a treatment plan? Lifestyle modification is always the first thing we talk about. My pharmacy students would always talk to me about like how much salt are they taking in. But my question to you is what else would you want to make sure your patient is doing in a lifestyle modification? Diet. And like exercise. Because what's the goal there? Weight reduction is one thing, and then the other key piece about that is like, could we get the body to work better overall when thinking about cardiac output, volume, et cetera, all these things that can either contribute to one, reducing weight, or just to improving the disease state. So when it comes to blood pressure, the other question I have is, let's say you end up initiating pharmacotherapy for your patient, and that patient is doing great on, let's go with like lisinopril 20 milligrams. So when do you take it off? Or was that a trick question and you actually don't take it off because they're doing great on the medication, right? So there are people like my dad who's like, last time I saw my LDL, my doctor said it was really good. Can I stop the atorvastatin, 40 milligrams? And I go, actually, sorry, your daughter's a pharmacist. 1, 2. No, because that's why your LDL is so good. So when I have this picture up here, like just to kind of keep your mind thinking as you're starting to eat, it was more just thinking about like obesity as a disease. And not to say it's not like I don't hear about TikToks or anything that has to do with weight loss medications. I have a 9-year-old and I have a 12-year-old. The 12-year-old has a hope. So she does tell me about things that are out there in the world, as she says, I don't know about. But there is things that have been going around about getting on these drugs for the short term. But really, obesity is a chronic problem. So why would I tell someone, let me give you a few months of this medication that can help you lose possibly 50% of your weight, only to take you off? That would never, because then you would probably get that weight back. So that's not my goal. I started off with hypertension because 1, it's so common, so is obesity. And 2, it's the fact that you wouldn't stop the blood pressure medicine because you know it's working. There is the concept of a J-curve in hypertension, I get it, all those kind of things, but the idea is you lower that blood pressure and you're feeling good about a stable breathing thereafter. So that was just to start, and just even thinking about the overview of obesity overall is how do you see it in the chart? How do you get notified that a patient has obesity? Who's a fan of this BMI, right? So one of the things that we always talk about, as a University of Florida Gator, I always say Tim Tebow has a BMI that would probably put him over the top and say that he is obese, overweight. And just to say the fact of the matter is it's not a perfect acknowledgement, it's an anthropometric measure, it's a way that we could say somebody is obese. But then, and other things that you talk about, you probably hear people mention pear shapes, apple shapes. Well, we don't always see a waist circumference in a chart, let alone do most people feel comfortable capturing a waist circumference. For those of you who have the pleasure of being outpatient, I've heard from a lot of our providers that a lot of prior authorizations are actually asking for a waist circumference. And in some instances, a neck circumference. What that's contributing to, I have no idea. But just more to say, these are things that are really capturing the essence of someone having overweight obesity, or when we're talking about central adiposity or other measures. The other thing that would be ideal is if we can have imaging. So a DEXA is not often done, but it has been done in study data, just to say, what are we doing to reduce fat mass versus are we losing muscle mass? So at least the DEXA would give us the most accurate picture of that because you really can't tell based on the BMI. So it's controversial. The other thing that I just wanted to point out is just the fact of transient obesity. Knowing that about in 2030, 29 million additional US adults will have it, nearly half of the US population. So whenever a patient does come into clinic, and I will also preface this to say that prior to coming on to Novo last year, I worked in an Ascension primary care office. But whenever we had a patient come in with their disease states or other conditions, we would focus on the other conditions, but we wouldn't focus on the weight because, one, we didn't want patients to think we were being a bully, which is insane to say, but so true for surveys. Two, we had a lot of patients that we were hoping they would bring it up because it was the concept of if it's not a problem to you, maybe I shouldn't say anything about it. But in actuality, weight can't wait. We should probably do something about it. If you think about comorbidities, most times you're talking about losing weight in order to improve that disease. When you're talking about dyslipidemia, why jump to pharmacotherapy when you could probably jump to at least to looking at diet or weight loss? When you're talking about PCOS, I'm not saying these drugs are indicative of PCOS, but insulin resistance is a big driver for that. So there's a lot of things that we should probably focus on the comorbidity versus focusing on just that comorbidity to help do the dialogue between the two disease states. So when it comes to clinical recommendations, and I'm sorry this is so small, actually now that I'm looking at it and going, can you see that in the back? It's just the fact of that the AACE and ACE guidelines, they do have recommendations on when you should really be focusing on what to do. So we talk about primary to tertiary management of a chronic disease. And what you can see here is starting at a BMI of 25 is when are you going to say to someone, well, maybe you should think about lifestyle therapy because your BMI is between 25 and 29.9. Or when do you start talking about weight loss medications? So as you can see here, weight loss medications you should consider after lifestyle therapy fails. So in essence, it's like if a patient didn't even try to do a diet, didn't even try to exercise, that's one thing. But they have to at least try, and then you could feel good about knowing, we've looked at that, let's go ahead and escalate to the next idea. And then furthermore, to say at a higher BMI, when should we consider bariatric surgery? And that's at a BMI of at least 35. So knowing you have a couple of options within the guidelines. Now, when it comes to overall eating and appetite signaling, I just bring this up because one, many of you just ate. You're about to go into your snooze fest, right? Because you just ate a very heavy lunch that we provided, but also to know that your satiety hormones are probably saying to you, we're full, we're not hungry anymore. But coming into this room, your hunger hormone, ghrelin, was saying to you, I'm so hungry, I could eat a horse, or just however you feel. But it's this gut and brain axis that's really regulating appetite. So it's like, how much are you taking in? How much energy are you eating versus how much are you expending? So as someone who graduated from pharmacy school a long time ago, I say 2005, feels like a really long time ago. But it's more to say that when I was a student, one of the big things we always said was calories in, calories out. Who's heard that? Yeah. When it comes to talking about obesity and overweight, that was always the rule. I think one of my professors was like, Nancy, you lose calories by sleeping. I'm like, okay, but I guess I'm not sleeping enough. I need to do more. But even just thinking about, if that were true, you should probably be able to fast for days and lose a bunch of weight. But that's not how our bodies work. There's more to that. So again, it's the gut-brain axis to say, what do we need to regulate and signal? Now, when it comes to our appetite signaling, there's a couple of different organs that you have to think about too with appetite regulation. So again, we have our stomach with that hunger hormone saying, oh, I'm still hungry. Or our intestines that do have a couple of different hormones in play, including GLP-1. Or our pancreas doing its thing when it comes with insulin and amylin. And then finally our adipose tissue and leptin and endothelin. And just thinking about what is going on within these different organs to say, I'm not hungry anymore, or I need more food, and just in general, how are we regulating energy? So the brain has a lot of things going on, and what I have on this left side of the slide is is talking about those satiety hormones and what they're doing, and hunger hormone as well. So if you're truly hungry in what we call homeostatic eating, it's like satiety and hunger are working together to go, I should eat, like I need to eat something, I have to because I'm hungry. But then those of us who were like me, where you fall sometimes in hedonic eating, today was a terrible day. My patient load was insane. I couldn't get anything right today. I'm gonna eat 3 cupcakes. Depending on where I went, maybe 3 caramel cookies. So anything can happen here where you're eating for pleasure, and dopamine is really driving my motivation. I only say this because it's like when you think about pharmacotherapy down the line, I want you to think about like the behavior pattern of your patient. If it's someone that has this reward system going on, you're probably going to want to think about the pharmacotherapy that helps with that, versus those who are having like something else that seems not behavior driven. It just seems to be that something else is going on that you don't think those drugs that target dopamine will really be the helper. And then just in general, we all have different things that drive when to eat, whether it's the time. All of us eat at lunchtime because it seems like the normal thing to do. However, it's also just like, what other things do you need to do to say, I actually don't have to eat lunch. I'm not hungry. You see that we have food here, but I don't feel the need to eat. Most people don't choose that option. So just thinking about like, what is our brain telling us to do when we think about our appetite? When it comes to chronic weight management, I always get a ton of great questions related to maintaining weight loss. So one of the key things that I always want to make sure I mention is that you have options. You don't have to, just because I walk around with a Novo Nordisk branded item, it doesn't mean that I'm saying to you pharmacotherapy. And neither is any guideline related to obesity management. In fact, it all starts off with talking about lifestyle. So just to say that therapies that do promote like weight loss are surgical is one option, pharmacological being another, and then lifestyle-based. And just thinking about what happens when you do lose that weight is your body adapts and says, what's going on? You just told me we're gonna do like a really intense boot camp, and now I'm extremely hungry. Anyone feel that? Like whenever you think today's the day I'm gonna actually try to lose so much weight, I'm gonna hit the gym, I'm gonna drink green smoothies, and then you're like, I am dying of hunger. Where is the next cheeseburger? Because I am taking that sucker down. That happens because your ghrelin hormone is saying to you, why are we doing all this like energy expenditure? We're getting real wild over here. This is not our normal self. So you're having this hormone that's coming up to say, we're hungrier. The other thing is just to think about your metabolism. So even when you do have great weight loss, your body doesn't care that that's what you did, that you got to this lower weight. It's the fact of saying, you got this lower weight, but nothing else changed about us. So we're still going to try to get ourselves back to where we were, because that's our set point and that's where we were for so long. So I think the other thing about that is it's challenging, it's chronic. And again, that's why I started off the slides with saying, like, do you consider it a disease? Obesity? Yeah, sure. The other thing being, it's a chronic disease. Because anyone you know that has really battled with weight didn't say it was a 3-month problem. They have told you, like, as a kid, I put on weight to join the football team because I knew I wanted to be a linebacker, or I had to lose a bunch of weight to be a ballerina, or I just wanted to look like a TikToker model. I don't know. But it is a constant argument of like how to get back to a weight that you're happy with. So just know that a lot of things, it's a cycle. And with weight loss, it has a lot to do with like economically, what can you pull off? Physically, what can you do? And then emotionally, which is why we always talk about intensive behavioral therapy. So what I wanted to highlight in this slide is what kind of weight management interventions are often followed by weight rebound. So a couple of things that always bothered me when I was a practicing pharmacist and patients would come in and tell me what they've tried. They would tell me, so I paid like $500 a month and I got on phentermine, and it was also prescribed a very low calorie diet. What's very low calorie? 500 calories. And I'm like, oh my gosh, I could probably just like not even eat enough, and that's not good. You cannot get to a very low calorie diet and consider that healthy and safe. So I had a lot of patients who did that. And there's a lot of folks who go aggressive with like looking at a modified diet and behavioral therapy, and then people who also try to combine the two. And what you're looking at is years post-intervention of like initially you have this very dramatic weight loss, but it's one, hard to sustain it. And then two, the other piece about it is your body at its set point to say, I can't keep up with this. Like, it's really hard to keep it going. So even if for those of you who ever watched The Biggest Loser with Jillian Michaels, and you saw all those people get like dramatic weight loss, they had a beautiful image of where they were and where they went. Well, unfortunately, what we also saw with those people is they regained their weight. So they didn't get to stay at what happened at the end of the show, but that was because it was so intense. Like, they went crazy. And then it came back to like real life, and then the set point of your body, and then they regained health weight as well. So although I love a lifestyle intervention, I also have to tell people it's not always just that. You may have to combine it with other things. And even when I talk about pharmacotherapy, it's still the idea that you're still doing something different in your life. I'm not telling people to start a drug and while you're at it, eat anything you want. You're still going to try to manage all those other pieces. So when it comes to treatment options for weight management, I just want to highlight the % weight loss when it comes to the interventions that are available. So even when you're looking at gastric bypass and gastric sleeve, we're looking up to 32% weight loss. And then the other key thing that we're kind of having a struggle with is like, is it always have to be surgery to get to that higher percentage? So whenever I would talk to patients about losing weight, I never told anyone to get to a BMI of 25. Because if you're at a BMI of 40, it feels impossible, like an unrealistic goal. So I always talked about the 5%. You could do anything to get to 5% weight loss. With lifestyle modification, with pharmacotherapy, even though lifestyle alone we're showing you is 3%, which doesn't seem like a lot, it's the fact of like, get those small wins, get started, be motivated. And then let's talk about pharmacotherapy. So we do have these options for weight management. Now the other thing is just to, again, no matter what you do, talk about intensive behavioral therapy. So this is the cornerstone that we always talk about with obesity, even though we know that we may have to add more depending on the patient's needs. But it's just the fact of like, can a patient pull off 150 minutes of intense physical activity per week? This is not today. And then ideally, if we can get 500 to 1,000 kilocal deficit daily, weekly, I mean, you could try to see what a patient can do. Because whenever we get patients started on pharmacotherapy, you want your motivated patient. You don't want your patient who's like, I'm willing to inject. I'm like, that's great. I just want to know that you're motivated in other ways and not just thinking about the medication as like the only answer. And then finally, this probably sounds a lot more like motivational interviewing where we're talking about goal setting. So like I said, I would never get a patient to talk about a BMI of 25 or less because it just seems so drastic and difficult. But I want to make sure that they are monitoring themselves, that they're thinking about when they choose to eat, and then they have social support if needed. If you can imagine, we have some of our drugs that are indicated for kids. So one of my favorite pediatric specialists in Mississippi, she was telling me how she has some 12-year-olds who are 400 pounds. And we were talking about it, and she was like, I'm so reliant on their families. So activating social support, because a 12-year-old being told that they have to like manage themselves, that's pretty hard. But if you have the social support around you to say, I can pull this off, what can I do to get to like a better weight that's ideal for my height and my age, then you need everybody involved. Because it would be difficult to come home knowing that you're trying to restrict the calories, but everyone else around you is just totally doing the opposite. So going back to the pharmacotherapy options along with lifestyle intervention and surgery is just to kind of take that same graph and just reiterate where do we fall. So pharmacotherapy being in the middle, our patients who need more weight loss, we have the surgical interventions, and again with lifestyle changes. And knowing still that even with very low calorie diets, you can get patients a little bit higher. Either way, you still want to shoot for these weight loss goals. And even when we do eventually talk about pharmacotherapy here, I think one of the key things is that I always harp on getting to that 5%, not just because we've seen that to be the case that helps with chronic disease states to get at least 5% weight loss, but also that's the FDA's mandate. So the FDA actually says that in order to be a weight loss medication, you have to be able to achieve 5% weight loss. So we can't just get any drug on the market to go, but Kim Kardashian just endorsed it. No, it has to at least have a 5% weight loss with it, just to say that it could be an FDA-approved drug. So going through pharmacotherapy for obesity, I just wanted to highlight a couple things. One, pharmacotherapy for obesity gets a bad rap because we've had so many drugs discontinued due to different disorders, whether most recently lorcaserin caused cancer, we had rimonabant with psychiatric issues, we've had other agents that have had heart attack and stroke risk. So it's been a bad history. And then the other thing to think about too is we had a lot of like amphetamines and things like that kicked off a lot of the weight loss, and that wasn't an appropriate way to go with obesity management either. So knowing that we had all these side effects, knowing that like it already has a bad rap for being very cosmetic, just thinking about what does this for pharmacotherapy. When it comes to current treatment options, we do have a couple of things. And one of the things that I did highlight is that phentermine is short-term. So if you ever have patients who are, for some reason, been on phentermine 5 years, I have seen that more often than I'm proud of, but it's more these people who reach for it and say, oh, I just keep it around to lose a few pounds. Or things that you go, well, that really wasn't the intent. The intent is to say, you've given it a try for 12 weeks, and then it didn't work for you. So how do we titrate up, right? Like how do we get to the next possible thing to be considered? So we do have a couple of options. Obviously I have devices on here, surgical options, and then of course lifestyle is still being consistent. I'll go through some of these pharmacotherapy options next here. So what you're seeing is like, in this slide is one, the actual generic name of the drugs, the dosing that's available, what type of drug class it is, what kind of mean % weight loss you're achieving, and also some side effects. So I only highlight this for you, and I'm going to go through a couple more clinical considerations shortly. It's just to say who's achieving the weight loss that a patient may need. One, is it orlistat? Orlistat gets about 6.1% weight loss, and orlistat has actually been a positive for saying that there's data out there to say that it can help with prediabetes, which is great. However, some people don't like orlistat because of the side effects associated with it. So it's like oily spotting, flatus with discharge, basically not attractive side effects. However, when it comes to talking to patients about orlistat, I say if anything, it's fixing your eating behavior a little bit, because all of those side effects are really affiliated with the amount of fat intake you're having. So if you tend to eat a lot of fried chicken or fried things, then orlistat is something that's like, hey, let's eliminate fat and then put it into your food, which I think is just an adjustment. So if you tend to not do that anymore, then it's almost reframing how you eat. With the phentermine pyramid combination, what you have there is, well, one, you have a sympathomimetic, so it's really helping with like that reward center potentially, but it's also helping with like satiety. So it's basically saying like, my appetite, I feel pretty full, I don't think I need to eat anymore. So that's one that's really been helpful too. But as you can see from that, you could get about, on the full dose, 9.8% mean weight loss. The other option that we have, that's another oral tablet, is naltrexone and bupropion. So if you're familiar with bupropion, it's been used for smoking cessation, it's been used as an antidepressant. But it's another thing that helps with that reward center. The other piece about naltrexone is it's an opioid receptor antagonist. So it can help again with signaling some of those satiety hormones too. But the weight loss that you've seen with that is again 6.8%. And lastly are basically the two drugs that my company is a part of, but I don't want to overly highlight it, but just to say it was really kind of a thrill to know that semaglutide had a 13.5% weight loss with it, which is getting closer to what can be achieved in bariatric surgery. Closer, I said. Not totally taking it over, but just to say it's a little bit better. And the only thing I always think about that is a really hard sell for people is to know that our drugs are injectables. So even when it comes to liraglutide, it's a daily injectable versus semaglutide, which is a weekly injectable.
How much time do you achieve that weight loss?
So the question was how much time for the weight loss? Well, with semaglutide, it is a titration every 4 weeks, so about 16 weeks when you get the full dose. So it takes a while for patients, which is why I'm not harping on anything being short term. It takes time. However, what we've also seen, and just in general, not with any specific drug, is a motivated patient will be motivated enough to lose a lot of weight in the first few months of being on anything. But again, they have to be very motivated.
So before we the semaglutide for weight loss, do we start with the 2.4 milligrams or do we up titrate to the 2.4?
So you start at 0.25 with semaglutide, and then you get to the max dose of 2.4. But it is every 4 weeks that they titrate. And I've had people ask me before if you can increase the titration right away. I was like, no, not if you want them to stay on it. If you want someone to feel really sick and feel like they don't ever want to give themselves the next injection, go ahead and get them on the 2.4. But if you want that patient to play the long-term game and also to feel comfortable, then you do the titration.
And then the mean percentage of weight loss was only with the medication. They weren't accounting also with lifestyle modifications, right?
So in this case, this is with coaching available as well.
Okay.
So that's another key piece with like both our liraglutide's brand name is Saxenda. With both of our drugs, when patients do get on them, you can actually be a part of a coaching, like a telephonic coaching system. So it's still encouraged, but that's still part of like lifestyle intervention. Mm-hmm. So I think that's the other key piece, just to say you should still have this on the side along with the pharmacotherapy. Mm-hmm. Any questions about these so far? Any other things? So just to again say like where are we signaling, what are we targeting to know like one, a lot of what we do is brain signaling when it comes to appetite regulation, when it comes to obesity, overweight management. And so I just wanted to highlight like where these drugs are acting in case you want to think about like what are we doing with orlistat being the only one that's working at the pancreatic lipase inhibitor. And then these other drugs really focusing on what can we do to help with satiety hormone, hunger hormones, and then also just thinking about this injectable that we have that's actually doing something in the gut, in the intestines, and also at the brain. So in case you've ever talked to anyone who's taking any of our, like Wegovy or Saxenda, I think the key thing too is like, they say, I definitely feel full. Like I'm actually not hungry. I don't finish a meal because I don't really want to eat anymore. So I think those are just some key things that I've heard. Now when I see that patients get put on something like bupropion, naltrexone, or phentermine pyramide, I've heard from some of our specialists to say those are patients who like to do the same reward things all the time. So I think last week someone told me they have a patient who really loves to open a bag of M&Ms and watch Netflix at a certain time of the day. Mm-hmm. So she has a specific behavior, and it's those kind of medications that could probably really help. So she was like, Nancy, is it okay that I didn't start her on the injectables? I'm like, no, I don't care. Like it's your patient, it's your clinical decision making. I think you should really think about what you're hearing from your person. They must open this bag of M&Ms. They must do this at this time. Like you're talking about someone who definitely needs help with the reward system. And then, like I said, if you have a patient that you know it's really about all the fatty food intake they have, maybe start here. Start with orlistat because you heard from them that they can't help themselves. This is what I like to eat all the time. And maybe it can help with a behavioral modification at the same time. So when it comes to like looking at your patient and what kind of things that maybe there may be or there may not be data for, I just wanted to highlight this because one, I'm on the medical side of Novo Nordisk, so I've looked at our guidelines, I've looked at the guidelines that are published out there, and I'm just thinking like, what would a clinician want to know? Because one, you would probably want to make sure, well, if they have uncontrolled hypertension, then I would probably not want to put them on naltrexone, trials.gov, but that is something that we are looking at, which we already have been studying in patients with type 2 diabetes. The other thing is I highlighted when I talked about the pharmacotherapy is the fact that I said that our drugs are both currently injectable. So what do you, like, if you were me, what would you want to see?
I'm scared of injectables, so I would think it's something oral. Yeah.
Okay, so you said it. So just to say that that's like something that we're in, like working and thinking about, but more to come on when that should happen, I can't say. It's more the fact of going like, could oral semaglutide be effective for weight loss? Like it's been effective for type 2 diabetes.
There's I was at this volunteer clinic earlier, this week, and I saw Risbellus.
Yes.
Yes. So is it mainly for the diabetes or is it?
That's what I'm talking about. So that's the oral semaglutide that we have indicated for type 2 diabetes, and we're currently looking at it potentially as an oral semaglutide for obesity. So we don't know yet. More data to come. Some things they don't tell me, and that's fine because I probably shouldn't know.
Sorry, with the semaglutide, right? Do you mind telling us the difference between the oral versus the injectable, like in terms of efficacy?
In terms of efficacy for a weight loss, I don't know yet. However, I do know that the dosing will be different, just because we'll probably need a higher dose of an oral semaglutide to be similar. One of the things that I don't have any pharmacokinetic slides because for a lunch hour, I wasn't sure. But I will say that Rybelsus is currently dosed daily, and then we're talking about a weekly semaglutide. So if you see the dosing and you're like, that's like way higher than 2.4 milligrams, it has to do with the pharmacokinetics of the oral agent, so that's why it will be a much higher dose that we're just looking at to see if it could even be done.
And then the other thing about the oral semaglutide is that actually you have to train your patient really well on how to take it because it needs to be like on an empty stomach, you need to be upright and everything. So people, even for diabetes, have issues taking that.
Think of it as the new problematic levothyroxine.
So there's the big elephant in the room. We know these drugs work, but most of the time they're not covered.
Medicine.
Yeah.
Yes.
So
Okay.
what does, for instance, the pharmaceutical company do to help with copay cards or patient assistance or things like that?
Patient assistance for weight loss medications is not currently current. For the copay cards, we do have a copay card that's currently available. You can go to wegovy.com, you can see it. That is more a question for Leanne just because that's what she does more. However, I will say too that when it comes to like, I guess I'm just thinking patients who know how to work the route of medications, they have to be ready to know that I prescribed this for you today, but that doesn't mean you're gonna get it today at the pharmacy because we have to go through a prior authorization process. These drugs are considered expensive, and so most insurances will have them as like, not a preferred agent, but let's consider it as long as you go through the right process for it. So Cover My Meds is something that's commonly used. When I used to work in the clinic, I would actually send things out like that before the patient even got to the pharmacy, just so I knew the process was starting without waiting for the pharmacy to call me. So there's also that. I think the other thing is your state is a tough state to work in. And I'm saying that lovingly as someone who covers Tennessee and Mississippi, but both Blue Crosses in Tennessee and Mississippi are paying for these things. But yet, Alabama, I've asked so many questions and I don't think it's gonna happen. I think the way insurance providers look at this, and again, I'm not an insurance provider, just someone who's listening, is they're concerned that if by 2030, 50% of the population is obese, that means 48, that many people will get this medication. But that's not the case. It's gonna be one, did you try lifestyle intervention first? Because we had to go through that. And then to say, did we try all these other things? And now we're gonna talk about this weekly injectable for you. So there's a reason prior authorizations exist. It protects the money, but it also protects the provider and the patient to say we're doing the right thing and we've gone through the guideline-driven algorithm for how to manage
So in the guideline-driven algorithm that we're talking about here, I'm just talking about the practical aspects of it. So what drugs do I need to typically fail to
Yes.
consider putting them on semaglutide?
It is 100% insurance driven. So even when you look at TRICARE this year started covering Wegovy, but they have, you have to throw the kitchen sink at someone in order to be considered. The other thing is, the reason I highlight the contraindications or considerations is because let's say you said, we had a patient with a seizure history, then it automatically rules you out with this drug. So you need to also be very clear about what contraindications exist for your patient to say, this is why I'm not challenging this one because of their history.
So I think she had answered the insurance question. So question is, when patients get on this, can they get it for life? Because I was reading somewhere that sometimes when they stop it, they have this rebound again.
Okay, so you did miss the highlights reel at the beginning. Highlights reel is stay on it, it's chronic. And the thing is, so when patients end up coming off these drugs, we don't want to say, oh, you've taken a nice hiatus from the very high dose of semaglutide. We'll just put you back on 2.4, but you have to restart the paperwork and restart the medication at the lowest dose. So I think the thing is that some insurances will also say, did you fail the drug? Is that why you stopped it? So you may have an instance where you'll have to add additional documentation. I don't know what they would consider, would you say patient had a drug holiday, patient couldn't afford it, what maybe something changed. But the other thing about insurance is, as you know, all of you signed for insurance to work at the hospital, minus the students now. But you signed up for an insurance and you want to look at your own formulary to say if it's even covered. Those are the things that you'd have to consider as well. I'm sorry, I'm going to take her and I'll come back.
What constitutes a failure?
What constitutes a failure? That's a great question. So with Saxenda, liraglutide, one of the things that we have in the package insert is that if by 16 weeks, did they lose a certain percentage of weight? So, and then the other thing so even outside of prescribing information, the other thing you need to think about is what would you consider a fail? If the FDA approved a drug, I said, with the goal of losing at least 5%, what would you clinically want to know that your patient did to say, I don't think after 3 months of trial this worked for them?
I need to ask, even before we consider pharmacotherapy, with patients doing lifestyle modifications, they seem to be losing some weight, but not as much as they would like. Is that a failure?
That would be how you clinically justify it. So let's say you had a patient who gained weight on Jenny Craig. They didn't lose any weight. Or if you had another patient who cannot do physical things because of an actual limitation to mobility. Those would be things that you would probably want to say to justify why I have to go to the next step. So in your clinical mind, what would you consider things you would probably put in documentation to say why I have to move on to the next thing?
So I think that one of the things that I like about the ACE guidelines is the fact that they're also taking into consideration the comorbidities the patient has.
Yeah.
So if you're not hitting a goal of weight loss and the patient's comorbidities are not getting any better, you can also start saying that the patient's failing this medication, this and that.
Yeah, you could say the patient has a history of poor kidneys or something that could maybe elevate why you're going to go to the next step. But also, again, we may have a lot of patients who actually do well with lifestyle interventions. So my husband will kill me, but I'll give him as an example. So he had a BMI of 31. He went to our doctor and he said, Nancy's company will pay for me to get a Wegovy. And I was like, well, that sounds really terrible, but okay. But the doctor, who I love because she always puts my husband in his place, said, I cannot write for you that you tried lifestyle interventions because we've never talked about this. And so she said, what I'll do is I'll go ahead and issue you a prescription just because I know that prior auths are a gamble. But in the meanwhile, I'm going to schedule to see you in 3 months to see if you actually implemented any of these lifestyle interventions. I didn't know why she sent out the prescription. That was weird to me, but I just thought, okay. Well, he was very surprised when he saw the prior auth denied, because it was denied. He didn't try any lifestyle interventions, so when she had to fill out that part of the paperwork, she had to say he's never done it. So there was that. And then by 3 months, his BMI is 29. So he actually doesn't qualify because pharmacotherapy with Wegovy is actually indicated for a BMI greater or equal to 30 or a BMI greater or equal to 27 with comorbidities, which he doesn't have. So there's that thought process of going like, having an honest conversation with your patients. There are some documents out there where you can have patients like write down what they've tried and failed, but that really is your clinical judgment to go, I need to know that you really did do this versus like, I'm just going to send out a prescription for pharmacotherapy.
I have one more. So you mentioned something about waist circumference, right? And we're still talking about BMI. How soon? You said some insurance companies are beginning to adapt or adopt the waist circumference, neck circumference. So when do you think it will take like a widespread uptake of
I don't know. Is hyperwastemia a disease? I don't know. So I just think like it's one of those things that when I see that insurances have valued that clinical measure, it's because they're thinking about metabolic syndrome, knowing that waist circumference is one of those parameters. But metabolic syndrome has been discussed forever since when I was a student, and really we have not targeted, again, this disease I created called hyperwastemia. So it's the fact of like just capturing it as another clinical measure, but also you can argue with your providers or with your insurances or something to say, here's the patient's waist circumference. I'm just giving you another compelling case to say then an apple shape is higher for cardiovascular disease. Who knows? But it would be your story to tell.
Yeah, and it comes down, I think, to I think the definition that you gave us at the beginning, that it says that, a lot of the patients may have a BMI over 30, but that doesn't mean that they are actually obese. So they just want to have like a waist circumference or the DEXA scan or the bioimpedance measurements. So that's what insurance sometimes would like to see. But AIDS guidelines has it in, but I think the World Health Organization doesn't have it as a definition just yet.
Yes, and I would always include any other compelling like lipid parameters if you have hypertriglyceridemia, if you have a very high LDL despite pharmacotherapy. I mean, these are all things that kind of tell a story. But also just to know that weight loss is still like indicated for a lot of disease states. It's just not something that people focus on. Even if you have a patient with an A1C that's well controlled, but they are still overweight, obese, why are we only focusing on the A1C when maybe we could still improve that parameter too? Things of that nature. Well, I thank you all for your time. I also don't...
So we're going to really quickly touch on the approach to GI bleeding. It's a topic we're all, I think we're quite familiar with. So it's just basically how we present management and some other tips here and there that could help in boards and just general day-to-day management. So clinical manifestations, let's see. Okay, so I think I wanted to really start straight with clinical manifestations. Typically, as we know, there will be hematemesis, melena, hematochezia, occult bleeding. Scrap that. So this is typically like for the upper GI bleed that, when we talk about upper GI. So we'll start with upper GI and go to lower GI bleed. So in upper GI bleeding, you get the hematemesis. We know the definition of that. But it's typically proximal to the ligament of Treitz. The bright red blood is significant bleeding. Coffee ground is no active bleeding at that time, but I mean, all of them should be taken into account the clinical picture of the patient before you determine how acute versus non-acute. The melena is passage of the black stools, hematochezia, passage of bright red from the rectum. And again, if it's brisk and significant, it's likely an upper GI source. Occult bleeding is bleeding that is not apparent to the patient. A lot of times, even in hospital here, you see a patient that has maybe blood thinners, their H&H is down, you check. They haven't complained of any bleeding per se, but when you check maybe a hem occult or something, you see a bleeding, or they could be symptomatic and you want to investigate why. Obscure versus occult. Occult is when it's not apparent to the patient. Obscure is typically when it's not apparent to the clinician or it doesn't show up in investigations. So those are two definitions that sometimes we confuse with each other. So the first step to approaching GI bleed is to assess the severity of the bleed. There's a minor, moderate, and massive. You want to see vital signs, which is very important. If typically the patient has normal vital signs, and they typically have less than 10% blood loss. If they have orthostatic hypotension, then it's about 10 to 20. And if they have shock, which is resting hypertension, is about 20 to 25. And then you want to go into resuscitation. Typically, yes, we go history, physical, and all that. If a patient is coming in with a GI bleed that's acute and has any kind of compromised circulatory or respiratory, you really don't want to be asking too many questions. You want to go straight to resuscitation. Vital signs should be monitored, of course, blood transfusion with target hematocrit of about 30% in the elderly. I mean, this, again, it's case by case. Now with the new guidelines where there's less than 7, don't transfuse until less than 7 or less than 8 in CAD patients. That has been captured there. So the elderly, you want to keep it up because, again, they have the tendency to have orthostasis and be more symptomatic. Patients with portal hypertension, you want to keep it within the 27 to 28 range because you don't want to trigger portal worsen the varices and precipitate bleeding with a higher hemoglobin. So if you are transfusing more than 10 units of PRBCs, you initiate a massive transfusion protocol. Here, I think sometimes they even do more than 5 units, and then they give 1 unit of FFP, 1 unit of platelets, and 1 unit of PRBC together. So that's something to consider. Okay, so now the patient has been stabilized, and you want to try and get a very good history from the patient. Elderly patients typically come in with a diverticular disease, angiodysplasia, cancer. Young patients come in peptic ulcer, varices, esophagitis. Less than 30, you can also see mucous diverticular. The patient with a history of previous bleeding, then you want to give a very good history about what the bleeding was, because that's most likely to be the reason on the current presentation. Aortic surgery is also a risk factor, or something that you can ask in pertinent situation. Non-liver disease, NSAIDs, very important. Because some patients, their chronic arthritis, you see it in the past medical history, should be a trigger to be like, okay, do you take NSAIDs, how often, how much, and all that. Retching, you get it in Mallory-Weiss, and then non-GI sources. Physical exam, there's stigmata of different diseases that could present with the upper GI bleed or even lower GI bleed, really. So you want to think about Kaplan-Meier and all those stigmata of liver cirrhosis or chronic liver disease. You think about these malignant paraneoplastic type of presentations in cancer. You think about pigmented lesions, progeria syndrome, cutaneous lesions. All these have, they present sometimes with angiodysplasia, so these can also lead to bleeding, splenomegaly, portal hypertension, because telangiectasias, you see them in a bunch of different conditions as well. So what are some causes? Some more common causes would be peptic ulcer, the varices, the Mallory-Weiss, and less frequent would be the Durofoils, vascular ectasia, watermelon, stomach, gastric varices, neoplasia, esophagitis, and quite rare would be esophageal ulcer, erosive duodenitis. Not sure why they termed it as rare, but just again, just to know in degree of frequency how often these present: hemophilia, Crohn's disease, and aortoenteric fistula. So we'll just touch on PUD very quickly. It's the most frequent cause of upper GI bleed. About 50% of patients will present with a bleeding peptic ulcer. It's especially common in the lesser curvature of posterior inferior wall, duodenal wall, and most ulcer bleeding is self-limited. Of course, if it's not, then intervention needs to be done, obviously. So predisposing factors would be the acid, like the gastric acids, HCl, H. pylori, NSAIDs, bisphosphonates, COPD, cirrhosis, anticoagulant, and ethanol. Okay, so this is just the Forest classification. There are a bunch of classifications for bleeding and for GI bleed in general, but if you just narrow to a few pertinent ones, Forest would be one of the more important ones. Stage 1A is the jet arterial bleeding, that's like it's just pumping out. Rebleeding is 90% chance of rebleed. 1B is just an oozing vessel, which is 50% chance. 2A is visible vessel, that's 25 to 30%. 2B is adherent clot, 10 to 20%. So sometimes if you see the EGD reports, you will see Dr. Wilkes, Dr. Hackstrom classifying the ulcer, what their findings as with the Forest classification. So these are just the classification. And this is the pictorial representation. I don't know if it's very obvious, but just basically. Anyway, so this slide I thought was important for me, so you guys, especially in clinical practice, patients come in on several NSAIDs and we're wondering which one is more dangerous or more more irritating to the gastric mucosa. So lowest risk would be ibuprofen, diclofenac. Moderate risk is the ones you can see highest risk. But from what I was reading, it said it is dose dependent. So just because it's low risk doesn't mean, of course, if the patient is taking a whole bottle every 2 days, it's going to increase their risk. So patients at increased risk of NSAID-related GI bleed will be history of complicated ulcers, especially a recent one, multiple or more than 2 risk factors, as you can see below: age more than 65, high dose NSAIDs, previous history of uncomplicated ulcer, concurrent use of aspirin, concurrent use of corticosteroids, concurrent use of anticoagulants. Okay, so I want to go from, finding out all the initial aspects of to going into the lab evaluation. You want to know your hematocrit and monitor that. Of course, we know that it may not always reflect the blood loss accurately in a patient who is actively bleeding. So take that number with a pinch of salt if you see that patient is, actively pouring out. So grossly elevated BUN, again, I think we're familiar with this. In GI bleed, it's quite a sign that, okay, this is something that's going on because of blood breakdown. Iron deficiency anemia typically would reflect maybe a more chronic process, low MCV, low ferritin levels, again, point to iron deficiency. So diagnostic tests and imaging, upper GI bleed, upper GI endoscopy, so the EGDs that we know, colonoscopy, small bowel endoscopy, capsule endoscopy, global balloon enteroscopy, barium radiant path. All these are imaging modalities, and they are picked based on, of course, the patient's presentation and the utility of why we would use them and the patient's risk factors as well. So in the treatment, patients must be adequately resuscitated. Like I mentioned earlier, you can start with IV fluids. while the blood is on its way. Upper GI endoscopy is the primary modality. You intubate the patient if the bleeding is severe or there's AMS, protect the airways primarily. Endoscopy therapy indicated in high-risk lesions and typically combine two methods, sclerotherapy, epinephrine, the band ligations, clipping, those are the coagulation and stuff. And then you probably proceed to open surgical management if endoscopic treatment failed and the patient is at very increased risk of death by hemorrhagic shock, something like that. So this was just again a pictorial presentation of esophageal varices. Here grade 1, grade 2, grade 3 post-surgical classifications, GI classification, and they're saying this is what they look like. I believe a lot of us have seen that. Typically, the ones we see them, band like dates would be these types, very big and tortuous. So I wanted to put that in there. Small varices are less than 5 millimeters, large are classified as more than 5 millimeters. And the variceal size is the best predictor of bleeding. Severity of liver disease expressed by child post score, which I'm sure we are familiar with in terms of A, B, C. And they said that there's something called red signs, which on varices also show that this varice is at increased risk of bleeding. So this is child post score. Bilirubin, albumin, ascites, encephalopathy, and INR are the parameters, and based on those numbers, do the calculation and get to the class that the patient is in. Smell score does, I believe, talks about 3-month mortality in liver disease. NA score is what a lot of us use, and find it an MD-Cal, very accessible. So dialysis, these types of creatinine, bilirubin, INR, sodium, and based on these calculations, you can estimate the 3-month mortality in this patient. So treatment of acute variceal bleeding. So best approach is to combine the use of pharmacological agent as well as the endoscopic procedure. So some of the pharmacological agents are terlipressin, that pain. Sorry, but octreotide, vasopressin, nitroglycerin may be used. They typically combine vasopressin and nitroglycerin. Apparently, nitroglycerin negates the effect of the vasopressin in terms of vasoconstriction and dilation. The drug therapy should be maintained at least 48 hours. I believe it's typically 3 to 5 days for octreotide. Said 5-day therapy recommended to prevent early rebleeding. The bleeding esophageal varices, band ligation is the endoscopic treatment of choice. Therapy may be used. Bleeding gastric varices, instead obturation with cyanoacrylate. TIPS is a rescue procedure, as we know, is kind of done in resistant or recurrent variceal bleeding when endoscopic treatment fails. And they said bleeding from the gastric varice may require early decision for TIPS. So treatment of acute is continued. You could do shunts as well, mesocaval graft shunts or traditional portocaval shunts, which may be an alternative to TIPS in child code class A patients. Blood transfusion, I think we mentioned that already. It's done cautiously to prevent precipitation of portal hypertension. Plasma expanders to maintain hemodynamic stability, as well as SBP prophylaxis that's given to all patients. Okay, so
you know.
This is just really talking about the shunt, general results, slash complications. We're saying that the bleeding actually is prevented or at least decreased, and races disappearing in about 6 to 12 months. Complications will be post-operative jaundice, increased cardiac failure. Also, hepatic encephalopathy may be transient, risk increases with the size of the shunt, and it is more common in older patients with the shunt. The saying of mortality is 5% with good risk and 50% in poor risk. So it's not just an end all be all. It's something that shared decision making and take the patient's clinical picture into individualized care. Okay, so this is just pictures of what is typically done with the lyrics. Alright, so we'll talk about Mallory-Weiss syndrome. It occurs in 5 to 10 of patients with upper GI. Typically in the gastric mucosa, and most of them actually stop spontaneously. And so if patient is not actively bleeding, the recommendation this was actually from the Gastroenterology Association, something like that. They said discharge promptly, or if there's active bleed, injection or banding. So we'll move swiftly to the GI bleeds. The more common ones are diverticulitis, vascular ectasia, which is the AVMs. Less frequently, you have neoplasia, you have IBD, radiation, colitis, hemorrhoids, small bowel sores, upper GI sores, which will eventually, obviously, symptomatically come down to presenting lower GI tract. Dural Lafoy's lesion can also occur on any part of the GI tract, so upper or lower, colonic ulceration and rectal varices. So this is a picture of a diverticular. These holes over here, very diverticular, and I think we know that. So Hyde syndrome, I thought was very interesting because it kind of happens quite often here. Patients present quite often, more often than I thought. So it's a multi-system disorder characterized by triad of aortic stenosis, GI bleed, and acquired von Willebrand syndrome. We said it's uncommon here, but it can lead to severe morbidity and mortality if not recognized promptly, and it can be missed, obviously, because sometimes people don't put those constellations together. Diagnosis, they said, is a direct result of circulatory, more like pathophysiology, direct result of increased circulatory shear forces and its effect on the physiologic conformation and subsequent cleavage of large von Willebrand multimers. In Hyde syndrome, there's increased shear forces which are caused by the stenosis of the aortic valve, and you see similar pathophysiology changes from other cardiac etiologies that cause an increased turbulence, such as HOCM, complications of LVAD placement, and severe MR, mitral regurgitation. The physical findings will be the evidence of aortic stenosis, obviously, the findings of auscultation, early systolic ejection murmur, pulse tardus, pulsus pulse tardus, laterally displaced point of maximum impulse, which is because of the high evidence of GI bleed is the second, again, because we're talking triad. Pain with palpation, blood or digital rectal exam, hemodynamically is unstable, hypertension, and then lastly, evidence of impaired hemostasis, bruising, hematosis, GI bleed again. So evaluation would be your typical CBC, coags, metabolic panel, fecal alcohol blood testing to establish if it's complete. The patient doesn't actively complain of that, but a lot of these patients are chronically bleeding. They come in maybe like with iron deficiency and anemia as well. So That would be important. Read the von Willebrand factor multimer assay. Platelet function assay, they said it's not very high yield, but something to consider in evaluation. So in management, you first establish, hemostasis before you repair the aortic valve, and then there's some von Willebrand replacement therapies. They said they have limited benefits in management. So approach to lower GI bleed is really not as acute. A lot of times it's not as severe as upper GI bleed in terms of acute management or emergent management. So they're usually less hemodynamically unstable. The most common cause of severe bleeding will be the diverticular, and most common cause of minor bleeding is a hemorrhoid. So the best, they said, controversial best diagnostic approach is severe with urgent colonoscopy. Slightly controversial, I'm not sure why they said that, but urgent colonoscopy, RBC, scintigraphy, angiography. So these are ways to find out where the bleeding is and the interventions that you need to do. Okay, so I just, I just added this here because I felt like this is important. We always, it happens to everybody, but I don't know if I'm able to retain this that much. So the more I see, the more I get familiar with some of these guidelines for colonoscopy screening. So we talk about the high risk adenomas, the quantity, and as well as the size. I don't want to confuse us all, but this was something I found very useful for us. In the spare time, we can go through it. I'll just put it up here so that we can be aware that this is a very important slide, especially in answering questions as well. This is another very important slide talking about colon cancer screening in patients at increased risk. So talk about, obviously now the guidelines have changed where before it used to be 50 years you start colonoscopy, now it's 45 years. Before it used to be 45 in like Black Americans, people with high risk, but now 45 is universal age. As according to UT, task force thing. Anyway, so yeah, this is yet another slide that I wouldn't really go into. But a good one to talk about is the ulcerative colitis, because that appears to come up in questions a lot. So 8 to 10 years post-diagnosis, I would stick to 8 years post-diagnosis and repeat every 1 to 3 years. I said 12 to 15 years if disease is only in left column. That's probably something that we can note too. I have a few questions, just to make sure everyone didn't sleep off while I was talking. Anyway, so do you mind reading this for me?
Okay, an 80-year-old woman is evaluated in the emergency department. She has a 48-hour history of 6 maroon stools and mild lower abdominal pain. No bleeding is witnessed during 6 hours in the emergency department. She has hypertension and coronary artery disease. Current medications are atorvastatin, metoprolol, lisinopril, omeprazole, and low-dose aspirin. Physical examination, BP 150 over 85, and pulse is 70. Abdomen is soft and non-tender. Hemoglobin is 10. Which of the following is most appropriate diagnostic?
This is for the medical students. So, you're ready for the answer? Yeah. Why do you say that?
Lower abdominal pain, 6 maroon stools.
Okay.
No upper GI symptoms.
I think, yeah, they were trying to capture the fact that don't get confused with this maroon stools to like be malignant. A lot of these lower GI bleeds do present with that because it's old blood and it's more chronic, and the patient is hemodynamically stable. They also mentioned that, excuse me?
Oh, I'm sorry, I'm thinking of what it was.
Yeah, I mean, look, is it that low? It's 10. Yeah, it's not that low, to be fair. But I think here they're saying the patient is hemodynamically stable, but if the patient was not hemodynamically stable, then you want to go to upper GI bleed more because they're more
Actively bleeding.
they move, the bleeding is more precipitous. So you would have picked up endo if it was hemodynamic instability. Yeah, the lower abdominal pain, I mean, sure, you can lean more towards the lower GI. So that was good, thank you. Can another person read this one, please? Someone else? Yes.
A 54-year-old man is evaluated for an 8-week history of postprandial non-epigastric abdominal pain after every meal. Pain begins 30 minutes after eating, persists for about an hour, and gradually resolves. He has had an associated 4.5 kilogram weight loss. He has hypertension, CAD, PVD. Current medications are aspirin, atorvastatin, lisinopril, and metoprolol. Vital signs are normal, BMI is 24, physical exam reveals epigastric tenderness and abdominal bruit. Upper endoscopy findings are normal. What do you do next?
Sorry? Yeah. I mean, we didn't talk about this to be fair, but just something to pick the brain.
I want to do B, so like he's having ischemia after illness.
Exactly. So it's that whole mesenteric ischemia type of picture. You want to see what's going on with his arteries in the mesentery. Okay, this is a good one. Yeah, sorry, I don't know your name.
A 55-year-old man is evaluated for follow-up after colonoscopy. He recently underwent colonoscopy for colon cancer screening, which revealed a 11-millimeter tubular adenoma. He has no family history of colorectal cancer. He has no symptoms and is not taking any medication. Which of the following is the most appropriate surveillance approach?
Which one?
A.
Yeah, it is A. Why did you say A?
Here's the table.
Oh, that's good. I mean, you captured that with the table. That's good. I thought the table was hard to read, but yeah, it's A mainly because of the size of the adenoma. Anything more than 10 would be typically 3 years, like the table said. So yeah, I think that is it.
Speak about pneumonia, a very common infectious disease process. Any idea what is pneumonia? What do you mean by pneumonia? Anyone? I mean, it is a lower respiratory tract infection, but which part is affected? Correct. So pneumonia is the infection of the lung parenchyma, okay? It's been commonly divided into community-acquired pneumonia and nosocomial pneumonia. There is a redundant term no longer used known as healthcare-associated pneumonia. So community-acquired pneumonia is acute infection of the lung parenchyma acquired outside healthcare facilities. And nosocomial pneumonia, which are of two types, hospital-acquired and ventilator-associated. These are when acute infectious process of the lung parenchyma is acquired within 48 hours, more than 48 hours of admission to hospital, or more than 48 hours of endotracheal intubation. This old term, healthcare-associated pneumonia, was used for patients who have been in long-term healthcare facilities or who have had recent hospitalization going back to 90 days. Okay. Why this term was made redundant was on studies they found that all the pathogens, the pathophysiology, everything kind of was same like community-acquired pneumonia. So they did away with this term, and right now we just have these three terms. Okay. This is another way of classifying, like if you want to read like atypical pneumonia, then aspiration pneumonia, chemical pneumonitis, and then bacterial aspiration pneumonia. Aspiration pneumonia is interesting because we'll study the treatment part as well. that why don't we give anaerobic coverage in this pneumonia, because all kinds of community-acquired pneumonia do have some kind of microaspiration going on, which is part of its pathophysiology. Chemical pneumonitis is another interesting type. It is basically aspiration of the the gastric juices, and not exactly any bacteria. So, and this presents quicker compared to aspiration pneumonia. So if you're having some infiltrates on chest x-ray, maybe within 24 hours of suspected aspiration, that's more likely to be chemical pneumonitis and not exactly pneumonia. These are some epidemiological statistics that community-acquired pneumonia has over 4.5 million outpatient and emergency room visits, and almost 650 adults out of 100,000 are admitted. So this, out of 4.5 million, 1.5 million are hospitalized. So it's a kind of huge burden to our healthcare facility, and up to 15% readmissions are also present. So duration of antibiotics and those things become very important. These are some of the risk factors, like which are part of those grading scales, using grading scales as well. So older age, any chronic comorbidities, viral respiratory infection, it itself is a predisposing factor to pneumonia. Then impaired airway production, smoking, alcohol, and crowded living conditions. Microbiology. So I think this table most of you guys know. I'm not going into details like typical, atypical, and respiratory viruses. What is interesting is the slide next to this one was the CDC EPIC trial, which was done some years back. It showed that in 62% of the cases, actually no pathogen was identified. So whereas Streptococcus pneumoniae is a commonest cause of bacterial pneumonia, but the most common cause, we don't even know what the pathogen is. And why it is like this, we'll understand once we read about pathophysiology. And Streptococcus pneumonia, though it's still the most common bacterial cause, but its cases are actually falling because of the immunization and vaccination. And the staph, Enterobacteriaceae, their cases are actually relatively increasing. So this is the graph the CDC EPIC trial had produced, like 62% no causes, total virus 23%, and if you see Streptococcus pneumonia is just 5% of the total burden. So this is the pathogenesis. Now pneumonia has both a traditional model and then there is a new model which came around some years back. So initially in the traditional model, what was thought that our alveoli is there are no intrinsic bacteria present in our alveoli. It's a sterile zone, like there are no intrinsic bacteria. So whenever we inhale through any pathogen, that goes to the nasopharyngeal mucosa, it multiplies there, and from there, because of microaspiration, it enters into the alveoli. So microaspiration is present in all cases of community-acquired pneumonia. Once it enters the alveoli, when the burden is sufficiently big enough and there is suppression of immunity, they start multiplying. When they start multiplying, the macrophages go there, they release some cytokines, which attract the neutrophils and all, producing more cytokines and inflammatory molecules, which damages the lung parenchyma or the alveolar capillary wall. And that damage and the transition of these neutrophils and these products into the bloodstream then causes fever, weakness, fatigue, and these kind of things. So this was the traditional model that the pathogen comes and then it goes to the blood and the infection happens. The new model says that alveoli is not a sterile zone. There are in fact actually some intrinsic bacteria present which corresponds to our oral flora. The bacteria they found were microaerophilic streptococci and some weird names like Vallionella and Proteonella, like these bacteria were found. Now interesting is these bacteria don't go commonly in our regular cultures. So the new hypothesis is that when the foreign pathogen comes, it not only produces the inflammatory response, but somehow the intrinsic bacteria also modulates our immune system to kind of fight against the foreign pathogen. So these two things happen, and from there the hypothesis came that by just foreign bacteria, any foreign particle like smoke or any dust particles which are in sufficiently big amount can stimulate some of these intrinsic bacteria to multiply disproportionately. When that happens, they will again stimulate the modulate the immune response and cause pneumonia-like picture. And in those cases, you won't really grow anything because it was those intrinsic bacteria which multiplied and produced the response. And hence, but that 62% which I mentioned about that you couldn't really grow anything, it's because this is the commonest cause. So this new model came around, I think, 3-4 years back. So this kind of revolutionized the way we think about pneumonia. I think clinical presentation, we all know we both have pulmonary and systemic, and we understand why the systemic signs happen when those neutrophils and those purulent materials come to the bloodstream from the alveoli. So diagnosis of pneumonia is basically a combination of clinical syndrome and chest imaging. Chest imaging, we should do PA and lateral both. If the suspicion is high and the imaging doesn't show anything, then we can consider CT chest, but CT chest is not routinely done. This is an example of lobar pneumonia, like pneumococcus. You can see the left lower lobe. And I'm not sure if it's clear or not, but this has like interstitial infiltrates on all over the lung fields. So this is kind of atypical pneumonia which we see from chlamydia, legionella, and mycoplasma. So radiographic patterns can help you in identify common pathogen, at least guess about it. Like lobar, the typical bacteria, then interstitial infiltrate, we discussed the atypical pathogens. If there is abscess or cavity lesion, there are higher chances of anaerobes being present, and that's actually one of the few indications where we do give anaerobic coverage by antibiotics. And then of course pleural effusion, you can suspect streptococcus and staph along with anaerobes. So the clinical picture and the chest imaging is done universally for all pneumonia patients. But these are actually some of the board questions, like we don't do these tests for all patients, but we should know when to do. So like the sputum culture, we have to do for any patient who is not responding to appropriate antibiotics in 3 to 5 days. Patient who is in ICU, a patient who has cavitary lesions or who has structural lung disease. And most of these patients will land up in ICU, so that's one of the indication. Then blood culture also for all ICU patients, and if you're suspecting MRSA or Pseudomonas coverage and you have started broad spectrum antibiotics, so this can actually help you narrow down the spectrum once the results are out. Influenza testing is important for all patients who are hospitalized during the influenza season. And the pneumococcal antigen and Legionella antigen are tested in patients who are in ICU or who are very sick in wards, regular medical floors. We'll discuss the treatment under these headings, like how to define severity and site of care, the outpatient and inpatient antibiotics, when to give MRSA and Pseudomonas coverage, when to give anaerobic coverage, the role of adjunctive glucocorticoids, and what is the adequate duration of therapy for pneumonia. So initially, this was the scale which we commonly use, right? The Curve 65. And this was so commonly used because it's easy to use. And they said that when your Curve 65 score is 0 for people less than 65 or 1 for people more than 65, because this itself gives 1 point, then you don't really need to admit the patient. But if the score is more than equal to 2 in more than 65 years old or more than equal to 1 in less than 65 years old, you at least need to admit the patient on regular floors, if not ICU. Score 3 or more, of course, goes to ICU. But then later studies found that PSI, that is Pneumonia Severity Index, this scale identified the lower risk patients better. It was a safer scale, more appropriate scale to use, and this was actually validated. Like Curve 65 wasn't really validated, this was validated. And they said that these broad headings like age 50 years, comorbidities present or absent, vital signs, and physical exam. If neither of them are present, the score is 0 and you can absolutely send the patient home with ambulatory medications, no need to admit. If any of the one major factors are present, then a step 2, this is the step 1 of PSI, then you go to the step 2 scale, and from there you identify whether the patient needs regular floor or ICU. So basically PSI score like 2 to 3 will go to regular floors, 4 and 5 goes to ICU. Then came the scaling system given by Infectious Disease Society of India and American Thoracic of America, sorry. And the American Thoracic Society. So this scale was actually useful to send patients to ICU. So if one of the major criteria present, like need for mechanical ventilation, or if septic shock is present, or if at least 3 of these minor criteria are present, so either one of these major or 3 or more of these minor, then the patient goes to ICU. So this scale became very helpful for sending the patient to ICU from ER, like here you have to go to step 1 and then step 2, here you can directly send the patient to ICU. So coming to the antibiotic, then outpatient, like once you have determined which area to send, then outpatient treatment can be done for people without comorbidities and people with comorbidities. So without comorbidities, either amoxicillin or doxycycline are preferred. Macrolide should only be given in areas where resistance rate is less than 25%. This change was made in 2019. Before that, macrolide was an equal option, but since 2019, it has fallen down because of the increased rate of resistance. Then the patients with comorbidities, you can use respiratory fluoroquinolones or beta-lactam with a macrolide. So who can tell me what are the respiratory fluoroquinolones? Not organized. Yes, good. Levo, good. What about Cipro? Very good. So Cipro, especially in vitro, they found that they're not so good for the lung pathologies. So it's mostly Levo and Moxi. And then oral beta-lactams are your amoxiclav or second generation cephalosporins like cefpodoxim or cefuroxim with a macrolide or doxy. Inpatient will depend on whether you have non-ICU or ICU. Non-ICU, you give this is what we commonly give, right? Intravenous beta-lactam like ceftriaxone with a macrolide like azithromycin or a respiratory fluoroquinolone. In ICU also, I'll mention about the special criteria separately, but otherwise ICU also is like that. Intravenous beta-lactam with a macrolide. If this is contraindicated, then you give beta-lactam plus fluoroquinolone. This is how it differs. Here it was all fluoroquinolone. Here, if you're giving fluoroquinolone, you have to give intravenous beta-lactam with fluoroquinolone. That means the patient is severely sick. These are, so we are not covering MRSA and Pseudomonas for all patients, right? So when we have to cover for MRSA, along with the standard inpatient therapy, we add VANC or linezolid. If we suspect Pseudomonas and add its coverage, then instead of the regular ceftriaxone, we have to give an anti-Pseudomonal beta-lactam or anti-Pseudomonal fluoroquinolone with the macrolide. Okay. The commonest risk factors in both these cases are previous identification of same infection, like previous MRSA in this and previous Pseudomonas in this. Then this also has previous hospitalization in 90 days. This also has previous hospitalization in 90 days. So these two are like common factors in both cases and which we can easily remember. Other risk factors for MRSA are like, if the patient has failed the conventional antibiotic therapy, then you start thinking whether MRSA is there or not. If there are any cavitary lung lesions, or if there is any suggestion of like septic pulmonary emboli. For Pseudomonas, the additional risk factor are any underlying structural lung disease like cystic fibrosis or bronchiectasis, any medical conditions which has led to repeated use of antibiotics in near past, and then hospitalization of parental, this we already discussed in past 90 days, or any immunocompromised patients. So in these patients, we have to add the Pseudomonal coverage. Then anaerobic coverage, what we were discussing in the initial part of the lecture, that we don't give anaerobic coverage for all aspiration pneumonia. Like in ambulatory patients, when you're giving amoxiclav, it's anyways covering anaerobic, but in hospital, only give anaerobic coverage if it's a visible aspiration, like it's a macro aspiration, and if the patient has lung abscess or empyema, which are higher risk for anaerobes. Otherwise, don't give routinely for all admitted patients. And influenza should be treated. If the influenza is positive in any patient with pneumonia, do treat it. So earlier there was this concept like treat for within first 48 hours. That doesn't hold true. Especially if the patient is admitted, irrespective of the duration of the symptoms. If it's influenza positive, do give oseltamivir or whichever drug you prefer with the antibiotics. So this change was made by IDSA 2-3 years back. In role of glucocorticoids. So we all know role of glucocorticoids in sepsis and then in ARDS. But non-ARDS pneumonia also there is some role. So if the severe pneumonias, I was talking about that IDSA, ATS scoring system in which 1 major or 3 minor are present, or the PSI score of 4 or 5, or 2 to 4 SIRS criteria are present, then you can consider giving corticosteroids, but just be sure that the patient is not immunocompromised, or the patient doesn't have diabetes relative contraindication, or the patient doesn't have influenza. In those cases, we don't give, but otherwise, we can consider giving prednisone 40 mg PO daily, or we can give hydrocortisone 200 mg split over 4 doses, and the duration is typically 5 to 7 days. So this is also as per the latest IDSA ATS guidelines. Duration of therapy, we have to give antibiotics till at least 48 hours the patient is afebrile and minimum of 5 days. Now in most of the cases, patients without comorbidities and the normal, regular, uncomplicated pneumonia, patients do start improving in 48 to 72 hours. So a 5-day course, what we typically give is sufficient. But if the patient has comorbidities, we can increase to 7 to 10 days. But if the patient develops those lung abscess complications or some stronger, like the strong pathogens like Pseudomonas or Staph aureus, in those cases up to 14 days or more, we can give antibiotics. But usually the uncomplicated pneumonia, which we should remember, is 5-day course. This we discussed. Another thing, like if the patient has started improving in 40 to 72 hours, but you do need to give antibiotics for 5 days. But if the patient is clinically stable, started accepting orally, there is no other reason to keep the patient in hospital, you can transition the antibiotics to oral and then give it for the rest of the days in an ambulatory fashion. And you don't need to keep the patient overnight just to observe that how the patient is doing on oral antibiotics. You can safely discharge. And there is absolutely no requirement of follow-up chest X-ray in uncomplicated cases. In only the patients who you think are developing complications or are not responding to antibiotics do you do a repeat X-ray. Otherwise, this is a wrong answer, like no follow-up X-ray required. This is another definition we should know, like what is non-resolving community-acquired pneumonia. When symptoms don't improve with at least 7 days of appropriate treatment, and these are some of the causes of it. And this is actually one of the commonest complications of pneumonia. These are the various pulmonary and extrapulmonary complications of pneumonia. As I said, non-resolving pneumonia is the commonest cause. Others are lung abscess, empyema. Then you have various other systemic manifestations and sepsis if the pneumonia worsens. Just couple of slides on hospital-acquired and ventilatory-acquired pneumonia. So we know the definition, right? It happens when it's more than 48 hours of hospitalization or on ventilator use. So these are some of the risk factors which we do in the which we base that use to prevent it also. Like, we give sedation in ICU, but we have to prevent ventilatory pneumonias. For that, we have to give those intermittent sedation vacation. All those tick boxes which we do in ICU chart, it's actually based on this. So like supine position is a known risk factor for ventilator associated pneumonia. So you elevate the head to 30 to 45 degree angle. Then oropharyngeal colonization is a risk factor, and we'll understand why it's a risk factor. And hence, that oral care with chlorhexidine and all prevents. Then physical conditioning, so early mobilization, early physical therapy to reduce duration of intubation. and prevent reintubation. So these are the risk factors and how we can intervene and prevent the pneumonia. Now, the steps we were talking about, like supine position being a risk factor, oral pathogens being a risk factor. Why is it so? Is that when we introduce the endotracheal tube, so our oral flora, there are a lot of pathogens, right? So sometimes seeding can happen at the tip of the tube. Or when the tube is already in place, and if you are not maintaining oral hygiene, those pathogens can multiply and create a biofilm covering both the external and intrinsic surface of the tube. And when that biofilm kind of breaks, those pathogens are let loose and they can go into the lung and cause pneumonia. Hence all those steps, like keep it 30 to 45 degree raise so that by gravity it doesn't percolate down. Do oral hygiene so that this biofilm doesn't get produced. Reduce the duration of intubation so that pathogens don't get sufficient time to multiply and create that biofilm. Diagnosis is pretty much the same way, except that in these patients we always obtain culture, be it sputum or blood culture. And treatment is a bit different. So in hospital-acquired or ventilator-acquired pneumonia, and this is not for patients who are hospitalized for community-acquired pneumonia. This is only for hospital-acquired and ventilator-acquired pneumonia. We have to cover staph and pseudomonas. So staph can be MSSA or MRSA, and pseudomonas will be monotherapy or dual therapy depending upon the resistance percentage in the ICU, in that ICU. So if suppose if there is no MRSA and there is no resistance for pseudomonas, then we can actually just give monotherapy with any of the beta-lactams or fluoroquinolone covering pseudomonas and one agent for MSSA. So just 2 antibiotics. Now, in case of MSSA, if there is suspicion for MRSA, like when the prevalence rate is more than 10 to 20% in the ICU, in that particular ICU, then you change this MSSA agent with agent for MRSA, okay? And if you have pseudomonas whose resistance prevalence is more than 10% in that ICU, or if the patient has structural lung disease, then instead of giving 1 anti-pseudomonal agents, give 2 anti-pseudomonal agents. This is the only indication for 2 anti-pseudomonal agents. Otherwise, 1 anti-pseudomonal agent is sufficient. That's all.
So, Chair, one question. Sometimes we get transfers from other hospitals or people who've just been discharged from somewhere else, and then come back with, again, like a prolonged respiratory failure or evidence of pneumonia. Should we code them as non-resolving CAP, or can we allow for that previous hospitalization and call it a hospital-acquired pneumonia? How do we work it?
So, because the patient, now we have to ask the patient or relative that was the pneumonia present when the patient got admitted to the hospital, or did the patient acquire it during his or her hospital stay. If the patient presented to that previous hospital with pneumonia, then it's community-acquired pneumonia. But suppose the patient had come in with stroke, had prolonged stay in more than 48 hours in hospital, and then developed pneumonia, then it becomes hospital-acquired pneumonia.
But if they don't know, then it's always just classified as community.
Then community-acquired.
So what's the duration if the patient gets discharged from the hospital and after 1 month or 15 days they develop pneumonia? Now what's the
That's community-acquired pneumonia. That's why healthcare-associated pneumonia term doesn't exist. What you are referring to, past 90 days, was an old term. So healthcare-associated is different, hospital-acquired is different. So that part is community-acquired.
So basically now healthcare is still community-acquired.
Yeah, so now we just have community-acquired and hospital-acquired and ventilator-acquired.
If the patient gets discharged and develop a pneumonia after 5 days of the hospital, then can what should we do?
That's again community-acquired pneumonia.
So what's hospital-acquired?
It's more than 48 hours from the day of admission to the hospital. During current hospital. During current hospital.